I'm here today. Oh, I'm here today. This is for Dr. Macy and my previous working relationship with her. That's right. And this is where she is now, the best picture I could find of the Chicago skyline. Let's see. And we will start now, and those will trickle in. Welcome. It is my pleasure to introduce to you Dr. Michelle Macy. She is an associate professor of pediatrics at Northwestern University, also the associate director of the Smith Child Health Research Center at Lurie Children's. And I didn't realize this, the research lead in telehealth. So I should not tell you about telehealth. The research lead in telehealth programs in the Division of Emergency Medicine at Lurie Children's. Dr. Macy, as you can see, is accomplished and wears many hats. She is by clinical training a pediatric emergency physician and also by formal training a health services researcher, hence how I know her. We go back when I was a early junior faculty at Michigan in general peds health services, and Dr. Macy was the fellow at that time, and then we shared an office wall for a good probably 5-ish years. So Dr. Macy, her research interests are improving healthcare delivery at the intersection of the ER, the office, and the hospital. Her research focuses primarily on primary injury prevention and healthcare decisions within the context of acute care, and specifically, for which she'll discuss today, she's the PI of an R01 funded project by the NICHD. That is no small feat for what I refer to affectionately as the Poverty Institute, given its low funding lines, to test the efficacy of an ED-based mobile health intervention to promote size-appropriate child passenger safety behaviors with the goal of reducing preventable injuries and deaths from car crashes. And so along those lines today, she will speak with us about her project entitled Tiny Cargo Big Deal, a precision prevention strategy for child passenger safety. Dr. Macy, the floor is yours.
Thank you, Beth, and thank you everybody for joining today. I'm going to make sure I can get slides advanced the right way. There we go. I don't have any disclosures other than my grant support from NICHD that Beth already mentioned with the R01, as well as a K23 that I completed. I like to start when I'm talking about my research to my origin story for why child passenger safety has become a big area of focus for me. And it really was a critical point in my career. I had just started my faculty position 3 weeks before Oliver was born, pictured here in the little blue sweater. And he was my third child. And with a third child came the problem of 3 kids that needed to be in car seats and a sedan that was too small to fit everybody. And so with the resources that I had as a faculty member and as somebody who had a spouse who was gainfully employed, we went out and bought a new car and problem was solved. But as I was getting ready to return back to work, I was awoken to an NPR story about the 3 states that were holding out on passing booster seat legislation. And there was a senator from one of the Dakotas who came on and said it's really a parent's right to choose how they travel with their child. And as an emergency physician who had taken care of families who had made choices that were suboptimal for their children's restraints, it got under my skin. And never had those parents that I'd taken care of with injured children said, you know what, I'm really glad I just did the minimum requirement based on the law because of the consequences that they were facing. And so with the work that we had available at the University of Michigan and the Cheer Center, I was able to take these ideas and start to build a research portfolio around child passenger safety. And this led to my first publication in this space and we used the CS Mott Children's Hospital National Poll on Children's Health to explore parent attitudes around booster seat use and the traveling that goes on as kids start to become more mobile, and this idea of carpooling becomes a piece of the equation. And what we did with this is surveyed a national sample of hundreds of families with 4 to 8-year-olds and learned that parents who had their children usually using a booster seat would often not use a booster seat when their child was traveling with their friends, and wouldn't ask another family to use a booster seat with their child if the child was getting a ride in a carpool. And we saw some moderating effects of this when the families were living in states that had more strict laws around child passenger safety. Those families were more likely to report using booster seats. And states with less restrictive laws were more likely to have their children prematurely transition to a seatbelt alone. And as I've built my career, I have really been drawn to determinants of health that fall out of the clinical care and genetics and biology, and are driven more by the social circumstances and health behaviors that people are engaging in. And we, hear a lot about the science of genetics and epigenetics and precision medication strategies for different things. And I'm much more interested in what we can do to shape behavior, recognizing that that is such a big driver of someone's health and well-being in this society. And one of the things that I often am up against when thinking about child passenger safety with people is, well, how big of a problem is it? And we, I think, have gotten really comfortable in this society with somewhere between 30 and 40,000 individuals dying in car crashes every year. And this top blue line shows motor vehicle crash trends from the 1990s to 2016. And you can see that even though we've had dramatic declines in the number of children who are killed in car crashes, it still remains the most common cause of death in the United States, far above fire and injury, neoplasms, and even a number of congenital anomalies and heart disease. So it remains a significant problem that needs to be addressed. When we look at fatalities among the children who are not yet learning to drive and who are most likely to benefit from child passenger restraint, we can see a similar trend from the last 30 to 40 years, that there's been an overall decline, and that we've had the greatest gains for the youngest children in the blue and black bars. And we've got some clear explanations for why we've had this downward trend. Things have really changed over time, and many of us who grew up in the 60s and 70s really didn't have much in the way of child passenger safety options. A lot of us can remember riding in the way back of a station wagon unrestrained, and that was a special treat. And we know now, with advances in vehicle engineering as well as car seat engineering, that we can really save lives and reduce these injuries. The first car seat safety laws were passed in the late 1970s. Tennessee led the country in that for car seats. And the first seatbelt law wasn't until the mid-1980s. Then there have been some significant engineering changes in vehicle requirements, with rear seat shoulder belts and airbags coming in the 90s and early 2000s. And in the early part of the 2000s, Washington State passed the first booster seat law. And since then, the majority of states have adopted similar laws. But we really see a flattening towards the end of this curve and potentially an uptick as the economy had recovered from the economic downturn in 2008, 2009, where we were seeing an increase in the number of crashes that are resulting in fatal injuries for children. And that's something that gets us in the way of the World Health Organization and international initiatives to drive us down towards zero deaths. We think that this is something that is achievable, and there are some countries around the world that are near zero deaths, but the United States has some more work to do on this front. And even if we are able to get to a point where we have zero deaths, the CDC estimates for every one child who dies, there are 25 who require hospitalization, 925 who are treated in emergency departments, and many more who are seen in doctors' offices. And we also know that the deaths are not, or the injuries are not evenly impacting kids of different age groups. So the children who are less than 1 have the lowest rate of injuries per 100,000 population in that group. And we see the highest in the 5 to 9 and 10 to 14-year-olds. And these injuries in part are tied back to the ways that individuals are choosing to restrain children in these different age groups. Folks who have attended public health training or are involved in injury research are going to be familiar with this Haddon Matrix. And it's a way for us to really think about where one would place interventions across the continuum of the pre-crash phase, the crash phase, or the post-crash phase, and then the different factors across the columns from human to vehicle and equipment to physical environment and to socioeconomic factors. And if we fill this in, we can see that there are a number of points of potential intervention. Human factors that are pre-crash include texting, buzz driving, speeding. Within the crash, the use of a car seat and doing so properly would be a human factor. And then for children, a post-crash factor on their injury sustained in a crash would be their skeletal maturity or immaturity. And we can look at things systematically by taking this organizing framework for injuries. The other thing that's important for the child passenger safety realm for particularly the first decade of life is the recognition of the change in physical maturity as well as muscle maturity and then behavioral maturity that occurs from newborn, where a rear-facing car seat is going to provide that best protection, to older toddlers and preschoolers who can use a forward-facing car seat with a 5-point harness, over to the school-age years where a booster seat can be beneficial. And then as we transition into older adolescents and folks starting to be independent in their transportation modalities, using the adult seat belts at every time. When we think about seat belts and the way that they protect us, it's really important for that belt to fit properly on the skeleton to be protective and avoid consequences of injury that result in a poor belt fit. And researchers have looked at how the belts line up across torsos of different sizes. So the red here shows a 8-year-old, and the white outline shows a 10-year-old. And you can see each of these black flashes indicate where that belt path would go from the D-ring above the shoulder where the strap comes down, and then where it anchors on the edge of the seat. And only 30% of shoulder belts are going to fit a child who is 6 to 8 years old. And this is why that booster seat becomes important. The other thing that is helpful for young children and up until kids are into early adolescence with a booster seat is it prevents this inclination they have to slouch, to allow their knees to bend over the edge of the seat. And when kids are slouching, that lap belt goes up over their belly and their back is pulled away from the seat. And so if there's a crash, that seat belt isn't going to engage on their pelvis or their sternum properly, and they're going to be subject to internal injuries to their soft tissues, as well as fractures to their spine as a result of that poor seatbelt fit. The American Academy of Pediatrics has long had guidance around what restraints are recommended at different points in childhood. And the guidance in 2002, when I started residency training, was really easy. And I think for a lot of pediatricians and even families, this still resonates in the back of their minds. You were to go rear facing until 1 year and 20 pounds, forward facing to 4 years and 40 pounds, and then booster seat until 8 years and 80 pounds. But over time, in 2011, there was enough evidence gathered to really push these guidances forward to better protect children. But with that, and with the complexity of the words on this slide, it became a lot harder to articulate what people should be doing with their children and how best to keep them safe. So the recommendations now are to use that rear-facing car seat until a child's at least 2 years of age, or until they reach the highest weight and height limits allowed by that car seat manufacturer. And then to go over to a forward-facing seat with a 5-point harness for as long as possible. And then use a booster seat until they are able to sit with an adult seatbelt. And we don't anticipate that's going to happen until somebody is 4'9" or 57 inches tall, and that's the average height of an 11-year-old. But everybody is going to grow at their own pace, and each seat has its own specific height limits and weight limits. And so the communication around this has become much more nuanced and challenging. And based on focus groups that we've conducted, it's caused families in some situations to just sort of throw up their hands and say, you know, we don't even know where to start with things. And that's been one of the guiding principles for the research that I'm doing, is what can we do to really simplify these messages and distill them down for families to know what's right for them. And out of the MMWR in 2015, we can see that children are using car seats more than 90% of the time for 1 to 7-year-olds. But as we get into those older children who are still going to benefit from a booster seat, we see a dramatic decline in that use. And there are a number of kids who are younger than 8 years old who would benefit from a more protective restraint than their families are using with them. And so we've got a combination of kids not using any restraint or using a restraint that wouldn't be as protective as possible, contributing to injuries and fatalities in this population. So we have 3 E's that guide the injury prevention strategies that we can take. engineering, which would be improved airbags, anti-lock brake systems, and car seats. Enforcement, which would be updating legislation to be more consistent with the guidelines from the American Academy of Pediatrics. And then also education, which is traditionally delivered in the primary care practice setting for families around child passenger safety. And there's a fourth E that I worked to incorporate into my research, and that is the E of equity, and really trying to be sure that we're providing the resources and information to families in a way that all children are better protected against the risk of injury and death in a crash. So one of the other early papers that I had in this space was a look at a data set that's compiled by the National Highway Traffic Safety Administration, or NHTSA, and they have done recurrent national observational studies of children, and they call it the National Survey of the Use of Booster Seats. But they look at all of the different child passenger restraints that are being used for children under 12 years of age as families arrive to common places that kids travel: daycare centers, fast food restaurants, recreation centers. And as families are parking, they approach the vehicle and document what they observe in terms of restraint use. And with this data set, we were able to demonstrate some of the first solid evidence of disparities in child passenger restraint use. And we considered restraint use appropriate to be age appropriate for children who were birth to 3 years using a rear facing or forward facing restraint, to use a car seat or booster seat for 4 to 5, to use a car seat or booster seat in 6 to 7 year olds, and then a car seat, booster seat, or seat belt for 8 to 10 year olds. And you can see here that the white bars are highest across all of the different appropriate restraint use categories, and the bars representing Black, Hispanic, and other racial ethnic groups are lower for appropriate use and higher for premature transition and riding unrestrained. And this riding unrestrained behavior is clearly the least safe choice that any family can make with their child and places them at the most significant risk of injury. And we see that as children enter into school age years, they have up to 20% of kids riding unrestrained. And then these premature transitions represent other opportunities for us to provide better protection for children. And you might think these data were published in 2012. This is clearly a problem that's been solved by now. But if we look at more recent publications from the National Survey of the Use of Booster Seats, we can see that this continues to be a problem with both premature transitions and unrestrained children. And so we have a continued need to address this in our country. And when we're looking again at the racial and ethnic backgrounds of children in this National Survey of Use of Booster Seats, we can see disparities are persistent with the Hispanic population in purple and the Black non-Hispanic population in red. So the core of the work that I do is really helping provide parents the answer to the question, is your child in the right car seat? And I'm not sure if these bulletin boards were well distributed throughout the country, but this was something that you would see driving down the highway in Michigan. And it poses this question, but it doesn't really give families the information they need to answer it. And so we've really sought to provide that answer to families. And did so with my K-23 funding, We were able to develop a tailored emergency department-based education program that included a brief motivational interviewing session that occurred during the child's emergency department visit. And then we followed up with families to provide additional tailored information in paper that was mailed to them that gave them specific guidance for their child's age, size, and their current restraint use behaviors. We had a conceptual model that has been one that I've carried on into the R01. And if we start at the left side of the model, we have the counseling in the emergency department filtered through the emotional state of the parent in that moment. And the goal of that counseling session is to promote their autonomy to make a safer choice, their relatedness, and their competence. And with the R01, we add in e-health or mobile health after that emergency department visit, recognizing that emotional state might contribute to how receptive they are to that information. The goal here is to increase parent motivation in the center oval and their intention to use the correct restraint, and then to support them with skills and ability for restraint use, to result in our outcome of improved observed restraint behaviors or an intention to make a size appropriate transition for their child. And we recognize that health literacy and numeracy will impact the parent's ability to uptake skills and abilities, and that there are a number of family and socioeconomic, vehicle, and stress and coping factors that also contribute to their ability to get to the recommended restraint being used on a consistent basis. These are the print brochures that we were able to develop for the K-23, and we had one developed for each of the transition points, and there was tailored information within the brochures. And we were able to recruit 339 parents into our study and accomplish randomization and 6-month follow-up with about 75% of them. We demonstrated that the ED-based intervention was acceptable, with more than half of parents who had received a motivational interviewing session finding that information helpful to them, and more than half of them identifying that they were very likely to share that information with friends or family. With the K budget, we were only able to reach about half of our parents at 1-month follow-up, and of those, 70% had positive feelings about their emergency department interaction, and 27% were neutral about the experience. We only had 11 parents share a dislike about talking about child passenger safety during the emergency department visit, stating that the encounter took too long or they felt the timing was bad. We also asked families their preferences for education, and 70% of them were interested in an online tool to help them know what was recommended for their specific child. 38% were interested in informational text messaging, and those who were not using the recommended or guideline adherent restraints were more likely to be interested in those reminders. In the pie graph, we show the proportion of families that were interested in at least some part of the interaction occurring within the emergency department, and all but the light purple and the dark purple had some interest and willingness to have interaction within the emergency department visit. A number of people, when they hear about this kind of work, are concerned that the emergency department is just not the right time for families, but these pilot data showed us that families were interested and willing to engage in this way. We also showed some signal that there was a benefit to the intervention with an increase of 6 percentage points in the number of, or the proportion of families that were using the recommended restraint at 6-month follow-up. And we showed no gains or losses in the control population. And so now I'm going to shift over to talk a little bit about primary prevention in the emergency department setting and using a precision prevention strategy here. If we look at population health, and think about that in the context of injury prevention, we're looking at laws and guidelines that get distributed to the population at large without any individualization of that information. When we're in a setting of clinical care, we might be able to identify different subpopulations, but often anticipatory guidance is delivered in a fairly consistent way with handouts or stock phrases that are shared with families as they're in this setting. And with a precision prevention intervention for child passenger safety, we are looking at doing the lightest touch of anticipatory guidance to those who have taken in these guidelines and laws that are delivered to the population level and adopted them. And tailored education to those who have thought about what is recommended and what is a part of the law, but might have some barriers to that that are filled just with education. And then for those who are up against significant motivational barriers or are dealing with different challenges with managing their child's personality or different family circumstances, using motivational interviewing as a tool to promote their autonomy to make a choice to use what is going to be best able to keep their child safe in a crash. So we went from this pen and paper guidance in the pilot study and went through a number of different iterations and design stages with paper wireframing and feedback from families to develop the mobile health intervention that we are now testing as a part of the R01. And this is one of the wireframes for the intervention that is active now. And you can see that the information ends up tailored for the child's name and their particular weight and height at the point that they're encountered. And it gives the family feedback that the forward-facing car seat that they're using with the yellow triangle exclamation point is not recommended, and that they should be in the green rear-facing car seat. And we're leveraging the technology for tailored education, and we're also using that to do collection of objective data, and then also to provide feedback on errors that we observe in child passenger restraint use that we collect on the families that we're working with. So this is a screenshot of the baseline information that we are gathering for families as they're enrolling in the study. And then the families who are enrolled in the intervention arm are given access to a mobile web application that is responsive to the screen size that they're using. So it'll look like an app when they're on their phones, and it'll look more like a website if they're on an iPad or on a computer desktop. And they'll be able to log into this platform and then have the more tailored information. And this is how the intervention looks in real life now. And families, based on the information we gather in the baseline survey, are given tailored tips that talk about their feelings and barriers to using a car seat. And we also provided families with a car seat calculator so that for children that aren't enrolled in the study, for whom we don't have all of the detailed information about attitudes, we can at least provide them with some size and age specific guidance for what's recommended to use when they're traveling with their kids. So with the R01, we're seeking to enroll 900 caregivers who have suboptimal child passenger restraint behaviors through a screening process in the emergency department. And we'll randomize about 2/3 of them to the intervention and 1/3 of them to the control condition, and then obtain in-vehicle photographs at emergency department discharge and do additional assessments of their behavior at 6 and 12 months. Those who haven't changed from suboptimal to recommended child passenger safety behaviors at 6 months will be re-randomized to either continue in the basic intervention with text messages and access to the website, or to an enhanced intervention where they'll have a second motivational interviewing session to review their continued barriers to child passenger safety recommendation following, and also have increased number of text messages. And then we'll do our final outcome assessment at 12 months. So one of the other pieces to the child passenger safety puzzle that we're looking to tackle with this project is going a little bit more detailed into how families are using the restraints and not just looking to yes or no, you've got a forward-facing car seat, but is that forward-facing car seat being used correctly? And there's a tremendous number of families that either don't understand how to use it correctly or are up against different vehicle obstacles to using car seats correctly. And that's where folks like Sadika Kendi and others who are trained child passenger safety technicians can really help out in one-on-one encounters. But we're hopeful that with the data we're collecting on this study and the text messaging that we're returning back to families, that we're going to be able to provide some additional benefit on the use of the restraints. And in the K-23 pilot, we were able to demonstrate that families are able to send photos of their children in car seats back to us, and that in those photos, we're able to identify errors and that we're able to achieve a moderate to high level of agreement when two reviewers score those photos. And so with that, we have a child passenger safety score as one of the secondary measures that we're looking at within the R01. And it's complicated at the surface, but it will distill down into a 100-point scale that will allow us to rank the severity of the errors that we see and deduct points from 100 accordingly, and then also gives us points for discrete text message feedback to give back to families and see if we can correct those errors that we're observing. And we have done a little bit of data collection to prepare and refine the CPass score. And for this example of a forward-facing car seat with a 5-point harness, the family has put the seat belt used to secure this seat in through the path that would be appropriate for a rear-facing car seat. So if this car seat were to get into a crash because that seatbelt's going through the blue channel instead of the green channel, the seat would kind of topple over on top of itself instead of being able to provide this child optimal protection in a crash. So that's just one example of an error that can be observed through remote data collection with static photos. And here's another example with an older child who is in a booster seat. And you can see that the way that the seat belt, shoulder belt goes over the armrest, that is an incorrect positioning for that and puts that seat belt into an improper position across his body and would put him at risk for injuries and would make that seat belt a little less protective for him, even though he is using the booster seat that we would want him to be in. So the last thing I'm going to touch on is the fact that COVID has happened, and that has required us to work to be nimble on this project to keep things going. And our team was recruiting in the emergency department during the month of February. And then when COVID began to be noted in the community in Chicago, we were no longer able to have the team in the emergency department in order to conserve PPE and minimize the risk of the staff members in that space. And so we've spent the last 2 months working on a transition to a remote recruitment strategy and for conducting an e-consent process. We are now going to be drawing from the population of parents who were seen in the Lurie Children's Emergency Department over the last 6 months. And thankfully, it was a really busy winter. So we anticipate that this pool will allow us to continue to hit our recruitment target. And then we already had in place plans for remote engagement with participants with the active text messaging throughout the study, the request for photos to come back from families. And then we've included the option for the 6 and 12-month follow-up visits to occur with a video conference call instead of an in-person assessment if we continue to be facing stay-at-home orders as the year goes on. And so with that, I have just a moment to acknowledge a ton of people who have been a part of helping me make sure that this work can move forward. And I'm not going to read names, but I will call out Dr. Trini and Dr. Kendi for their contributions and support over the years. And with that, and I'm realizing the way this is set up, I have no idea how I did on time, but hopefully I'm okay, and I'd be happy to take questions.
Perfect on time. Excellent. And I'm so impressed that you've been able to find a way to modify the study to keep it going. In some ways, do you think this came up? I know this from Dr. Kendi's recent work on her project. Do you think that this provides an opportunity? So moving forward, you might be able to basically get the same, if not more, information in an equally valid way with fewer resources? What do you think about that?
I am going to be interested to see how this remote recruitment strategy plays out in terms of yield from families who are willing to participate in the research, but I'm optimistic that it will be more efficient. When we're doing real-time recruitment in the emergency department, it's a dance to try to catch families, and we were not approaching families in the waiting room, so we had wait room times that were on the order of hours. And by the time a family got it back into their emergency department room, a number of them were not really interested in doing anything other than getting home. And so if we're able to follow up remotely with email and phone communication with individuals when they're not feeling exhausted from being in the waiting room or stressed from that situation, I do think it increases the chances that we're going to be able to get higher recruitment in a more efficient way.
Do you use that when you follow them? You may have said this, I missed it. Do you use the portal information, or you just use ED records?
So we are going to be pulling from ED records to identify families, and if they have an email listed, we're going to use that as our initial strategy for reaching out with a screening survey link that'll be contained within that email communication. But for those who don't have an email listed, and we understand that families that are just seeking care in the emergency department and they're not part of the Lurie network otherwise are probably less likely to have an email in the system, that we will still have those other channels to be able to reach out to folks.
What about text messaging?
So we do have the ability to do text messaging, and I don't know, we did not script any text message kind of cold call communications, but if we're not successful with the email phone contact, I think that that would be a way to go. It's just tough to get everything down into 160 characters.
Good points. Good points. Are there questions from those in the audience? Thoughts, comments? I thought the precision angle was fascinating. How did you come up with it? It's a nice example. Sorry to ask a question then, but it's a nice example of using a framework from another part of science and medicine and applying it conceptually in a way that works. So I thought it was brilliant. How did you come up with it?
So I'm going to have to credit Flora Winston from the Children's Hospital of Philadelphia for putting forward an opinion piece type article into the literature that coined the precision prevention. And that piece was more broad than to child passenger safety, but it felt like a concept that really resonated with the way that I was approaching this. And so did include it in the R01 application as a conceptual framework that I do think plays well against the other scientific domains that have adopted that as a innovative strategy.
I have another question, which was not in the presentation, but I think for some faculty who, especially ones who've just transitioned here, can you speak, you were awarded an R01, similar to me, awarded the R01 and then transferred it to a new institution and preserved the scope as in its entirety, and the NIH was fine with it. Can you showing the sort of fluidity of much of the work that you do? Can you speak a little to that? And then Dr. Kendi has a question on the chat.
Yeah, so on that transition, I think that I was lucky in timing to have a very positive score and all signs pointing to it being funded, but I was leaving the University of Michigan before the award was issued. So we were able to, I think, minimize the administrative burden by asking the NIH to hold the award over the summer until I started in Chicago in September. And then the ability to continue to subcontract back to all of my co-investigators at the University of Michigan who were critical to building up the mobile site and the texting platform, and also in the development of the child passenger safety score, was something that allowed us to remain in scope and be very consistent with the original grant proposal. I think the biggest adjustment that we made with the move was the proportion of the emergency department population in Chicago that is Spanish speaking is in the 30 to 45% range for parents. And in Michigan, it was less than 5%. And so we did add in a component of a Spanish-speaking arm of the study. So everything's done in parallel now. But I think one thing that I, in hindsight, wish I had known was the idea of an administrative supplement to do that additional work. And it just was something that we built into the work to be done without thinking about that administrative supplement concept until the work had already been done.
Now, on the plus side, that's a good point about the administrative supplement. Now, on the plus side, you will have a niche in the world of child prevention, child injury prevention, passenger safety in Latino populations.
Yeah.
Dr. Kendi asks, what do you see the future of optimizing child passenger safety looking like?
Is that a since COVID and nobody can go anywhere question, or
since there are no, in general?
Yeah, I know. So I think that the more that we can provide families with actionable, individualized information, the more they're going to be able to do what's right for their child. And so I'm hopeful that we can shift away from kind of broad brushstroke recommendations that come out in the primary care encounter, like stay rear facing until 2, or forward facing in a car seat until you're 4, and really channel families into these more informed sources of information where they can get personalized feedback on, when it gets really hard to use the restraint, how do I overcome this challenge? And using these more virtual interactions with specialists who have child passenger safety expertise where it's needed. And when families are clicking along and getting it, not having those resources needing to be invested into those channels. I think another space that we really need to be mindful of is we're shifting into a different mode of transportation for a lot of 20 and 30-year-olds. And so as car ownership becomes less a part of the way we get around, I think we need to encourage the car seat manufacturers to work on designs that are more intuitive, more portable and transportable, and easier to install quickly so that we're able to meet the needs of families that don't own vehicles and rely on rideshare or taxis or other services.
That's a good point. And then Annie asked, which is an excellent point, the process for developing the mobile app. Did you work with a hospital, an external vendor, someone else, other entity?
Yeah, so a lot of the mobile app development work occurred with engineering and art and design students at the University of Michigan. And so I think that the lesson that I heard over and over and over again is that build and build and build and build outside of programming something out as much as possible. So draw things out, get feedback on those sketched images, have somebody flip through pages that would simulate the app that you want to build. Then I had a student build something called clickable wireframes so that if you hit this button, you would navigate to the next screen. And you just learn so much from that experience and user-centered design that then when you're ready to do the actual build and programming of it, you're not making a bunch of programming tweaks at the back end, and it's a much more efficient way to go. The actual building of the mobile app was done with my collaborators in the Center for Health Communications Research at University of Michigan. And so that was the way that things made sense for this project. But along the way, we did have a number of conversations with different app developers and startup companies. And I think there's just a lot that can be done before you write a $10,000 check to somebody to program something out and then say, oh, wait, that really wasn't exactly what my patients or families need. And so can you redo it? And where is that next $10,000 coming from?
It sounds like a good paper.
Maybe we could write it together.
I don't know anything about apps, but I think it'd be a good paper, because anything that, you know, can help with this sort of general approach for those who don't have a communication center like we did at the University of Michigan, I think would be very valuable. And I'm sure we could find a journal. Maybe
there's always a journal.
Maybe pediatric research from SPR.
Yeah.
Let's see. Other questions? We have 3 minutes before the hour. I'm happy to close. If there aren't any questions, this was great.
Thank you, guys.
This was wonderful.
It's a little bit funny without faces, so
I know it is.
Thank you guys for rolling with me on this.
It's something to get used to, right? You just have to pretend like there's such feedback which you don't have. So I want to thank Dr. Macy for giving us a wonderful presentation on her work, and especially the nimble way gives us hope that she has pivoted with her project. And then want to remind everyone that next Monday, our next enrichment series at 12 p.m. is Mindfulness Interventions to Prevent Mental Health Problems and Promote Resilience with Dr. Tamar Mendelsohn. This is co-hosted by the Behavioral Medicine Research SIG, so thank you to them. And also to remind everyone that tomorrow is our 11 a.m. faculty support virtual meeting, and we'll be going over some of the technological or programs we've used, like, let's see, we talked about rather in the other session, Slack. I forget them off the top of my head. I'm gonna see if we can get someone to talk about Trello. I think Google Voice was one of them. Dr. Streisand may have a better list, but it's going to be much more hands-on and pragmatic. So those of you that would like to join, you're of course always welcome, and I'll decide where I will be phoning in from in the interim. So thank you all for joining us. Stay safe and stay sane.
Thank you. Thanks for having me. Yep, good to see you.